This talk aims to give a relatively clear and hopefully relatively simple overview of arrhythmias. Your learning outcomes include that you should be able to recognise common arrhythmias such as ventricular tachycardias, AV nodal reentrant tachycardia, atrial fibrillation and bradycardias, including heart block. So that's really what we are going to focus on today. Remember, these learning outcomes take you up to phase 3. I'll also describe the initial management of arrhythmias in a very much an overview form, and in the future we'll talk about pacing, but that's not going to form part of this talk today. An arrhythmia simply refers to an abnormal heart rate or rhythm. Symptoms of arrhythmias can really be quite variable. There are many people that have arrhythmias that are completely asymptomatic, and the only time we'd know they'd have an arrhythmia is just incidentally when a ECG is performed for another reason, say if they were having a surgical pre-assessment. There are those that present with palpitations or strange sensations in their chest. There are patients that present decompensated, so in cardiac failure or otherwise unwell. There is presentation with syncope or sudden collapse. And then, of course, there are the unfortunate people who their first presentation is with a sudden cardiac arrest. Let's move on to talking about the types of arrhythmia. We can divide arrhythmias up into tachyarrhythmias, so those which are tachycardic, so greater than 100 beats per minute, and bradyarrhythmias, which are associated with a heart rate of less than 60 beats per minute. So firstly, under bradyarrhythmias, we can have sinus arrhythmias, sinus pauses, or sinus arrest. A patient may have sinoatrial node disease. This would be a dysfunction of the sinus node, and this can sometimes manifest as a inappropriate sinus bradycardia, or sometimes periods where the sinus node isn't acting at all, so periods of sinus pause or sinus arrest. Depending on how severe this is and how long those pauses are, these patients may require a pacemaker. Another manifestation of sinoatrial node disease can be what we call sick sinus syndrome. So here patients experience episodes of both bradyarrhythmias and then episodes of atrial tachycardia, such as atrial fibrillation. And again, these patients may require a pacemaker, and in sick sinus syndrome, this then allows us to treat the patient with, say, beta blockers for their tachyarrhythmias without making their bradycardia or SA node disease worse or life-threatening. The other major category of bradyarrhythmias is atrioventricular blocks. Firstly, we have first degree AV block, and this is simply when conduction within the AV node is slowed. It's a benign condition that doesn't often progress into higher degrees of blocks and does not require any treatment. Second degree AV block is broken down into type 1 and type 2, often referred to as Mobitz type 1 and Mobitz type 2. This second degree block can be of variable significance. A type 2 second degree block will always require a pacemaker, whereas a type 1 second degree block only sometimes requires a pacemaker. third degree AV block is also known as complete heart block, so there is no signal transmitted through the AV node. These patients always require a pacemaker. I don't want to dwell on this too much now, but it's also worth noting that a patient that is in permanent AF, so normally has a irregular rhythm, if their ECG or their rate suddenly becomes regular or slow, this is a equivalent to complete heart block. Moving on to our tachyarrhythmias, the first question we can ask when someone has a tachyarrhythmia is their QRS duration narrow or broad? So if it's narrow, that's less than or equal to 120 milliseconds. And then we would ask whether their rhythm is irregular or regular. If they have a narrow complex QRS and their rhythm is irregular, the vast majority of the time this is going to be atrial fibrillation. If they have a narrow QRS complex and the rhythm is regular, if there is a clear P wave before every QRS complex, then this could simply be a sinus tachycardia. However, other arrhythmias that would fall into this category would be the AV node reentrant tachycardias and the atrioventricular reentrant tachycardias, and also atrial flutter, where there was a consistent block through the AV node. So flutter with 2-to-1 block would be a regular narrow complex tachycardia. A broad complex tachycardia would be one in which the QRS duration is greater than 120 milliseconds. Again, we would ask whether the rhythm is regular or irregular. If it is a broad complex tachycardia and the rhythm is regular, the first thing that should spring to your mind and what the ECG should be considered to be, unless proved otherwise, would be ventricular tachycardia. If the QRS is broad and the rhythm is irregular, the diagnosis to exclude before you do anything else is ventricular fibrillation. Like with all ECGs, try to get into that habit of having a really nice structured modular approach to how you go through things. But as highlighted in the previous slide, the thing with arrhythmias that you really want to draw out is firstly the rate. Is it fast, and if so how fast? Is it slow, and if so how slow? And then after that, is it a broad or narrow QRS, so greater than 120 milliseconds or less than? And then is the rhythm regular or irregular? And even if you can't name the actual rhythm that the patient is in or what the ECG is showing, and often we can't, often I can't, often the cardiology consultants can't, we're not sure exactly what that ECG shows. But what we can say is whether it's a, let's say, broad complex tachycardia that is regular at 200 beats per minute. And that is enough to deal with that urgent initial management. And if you're the junior doctor on the ward and you've got an ECG, you can phone for advice. And if you're able to phone the cardiac outreach nurse or the cardiology registrar and are able to say, I've got a patient with a narrow complex regular tachycardia at 150 beats per minute, that gives them a really good idea of what they're dealing with. Let's start by looking at the bradyarrhythmias. And the ones that I really want to highlight here that you should be familiar with are the AV conduction blocks. Starting with first degree AV block. Here's a very simplified animation of the electrical activity in health. So the impulse travels through the atria, is slowed through the AV node, and then travels through the ventricles via the bundle of His and the left and right bundle branches. In first degree AV block, conduction is slowed across the AV node. This gives a prolonged PR interval, so greater than 200 milliseconds on an ECG. However, first degree AV block is benign. So let's look at how this looks on the ECG. So our PR interval on our ECG reflects conduction through the AV node. So if our conduction through the AV node is slow, therefore our PR interval is going to be longer. That PR interval being the time of onset at so the beginning of the P wave until the start of the QRS complex. Normally this interval is 120 to 200 milliseconds long, so that's 3 small squares to 5 small squares. In this example, if you calculated it, the PR interval is 320 milliseconds, so that's 8 small squares long. So this PR interval is consistently prolonged across the ECG. So this is an example of someone with first degree AV block. Let's now move on to talking about second degree AV block. We'll start talking about second degree AV block type 1, which is also known as WENCHEBACH. Here's a short animation showing second degree AV block type 1, also known as WENCHEBACH. So what you're seeing here is the PR interval progressively prolonging with each beat until a beat is dropped, and then the pattern repeats. This is due to impaired AV node conduction, although it can also be due to drugs such as beta blockers or high vagal tone. In some people, this is a benign condition, but it does sometimes require a pacemaker. Let's look at how this appears on an ECG. Your first PR interval in the sequence may be normal, so 120 to 200 milliseconds, or it could perhaps be slightly prolonged. The next PR interval is longer than the first PR interval in the sequence. The next is even longer. And after the next P wave, we drop a beat or a QRS complex. The pattern then repeats, so a relatively short PR interval, longer, even longer, and then dropped. Moving on to second degree type 2 AV block. Let's again start with a short animation. Here, only every other beat is transmitted through the AV node. So every second beat is being blocked. So this is an example of 2-to-1 second degree type 2 AV block. Usually this is due to structural AV node disease, and it is known to almost always to progress to complete heart block. So this is a condition that definitely requires a pacemaker. Hopefully after watching that animation, the way the ECG looks is fairly intuitive to you. So you would see a P wave followed by a QRS complex, and then a P wave, which has then no QRS complex following, and then the next P wave is followed by a QRS complex, followed by one which has a drop beat. Another way to think about this ECG is to think that it looks like someone has just gone through with a razor and erased out the QRS complex after every other beat. If we add them in like I have done here, so pop them back in, and the rhythm and the rate looks completely regular like a normal ECG. The example we've looked at so far is a 2-to-1 AV block, so it's every other beat that is being conducted through the AV node. It's also possible to have a 3-to-1 second degree AV block, so in this example it would be only every third P wave that is transmitted through the AV node to give a QRS complex. Again, the ECG looks like someone has just simply erased the QRS complex after every second and third P wave before the pattern repeats. And finally, the most serious, the third degree AV block, otherwise known as complete heart block. Again, we'll start with a short animation. Here, the AV node is completely blocked, so there is no conduction through it. So the SA node continues to fire, but none of these impulses are transmitted through towards the ventricles. The ventricles will start to often pace themselves, but the ventricular pacemaker cells are at a lower intrinsic rate, so this is usually fairly slow. And this is also a much more unstable pathway than conduction coming from the SA node. This is also always due to structural disease of the AV node, and because those ventricular pacemaker cells are unstable, if untreated, usually it will result in death in less than 6 weeks. It therefore requires an urgent pacemaker, and if the patient presents with syncope or with profound bradycardia, that pacemaker needs to be immediate. On an ECG, you can usually see P waves and QRS waves, but there is no consistent relationship between those P waves and QRS waves. As the SA node continues to fire regularly, you will see P waves marching on through at regular intervals. Here you can also see QRS complexes marching on through at their own slower rate. However, there is no consistent relationship between the P waves and the QRS complexes. Even though it doesn't technically fit into either a bradycardia or a tachycardia, I am now just going to talk briefly about bundle branch blocks. A left bundle branch block does what it says on the tin, so it is a left bundle which is blocked. So electrical activity starts in the SA node as normal, is slowed through the AV node, travels down the bundle of His, but when it gets to the left bundle branch it is blocked. Signal therefore travels down the right branch, and in order to depolarize the ventricle, signal must travel across from the right side through non-specialist conductive tissue, which is going to take much longer than the normal specialist conductive pathway. This is why you get a broad QRS, because that depolarization takes longer. Here is an ECG of a left bundle branch block. So on top of the broad QRS, so greater than 120 milliseconds, there are a number of other classical features. In leads V1, V2 and V3, so the anterior leads, but by definition, especially in V1, there is a deep S wave. Note that this is a S wave because you've got the small upwards deflection and R wave preceding it. You often also find that you have a broad dominant R wave in the lateral leads, so leads V5, V6, 1 and AVL. Students often like an easy way to remember things. I often find the ones for the left bundle and right bundle more confusing than they are useful. But one thing I would say is that the deep S wave that runs down the anterior leads looks remarkably like a large kitchen knife stabbing down through those leads, and the broad dominant R wave in the lateral leads could be compared to a bullet. Moving on to right bundle branch blocks. So here it is the right bundle branch that is blocked. So signal comes from the SA node through the AV node. When it gets to the right bundle branch, it is blocked. Signal therefore travels down the left bundle branch, and in order to get across to the right ventricle, it has to go through that slow, non-specialized tissue. So again, it takes longer to depolarize across to the right side, making the QRS again broad. So a broad QRS, but also some other classical and definitive features of a right bundle branch block. Those being a RSR pattern in V1, V2 or V3. This is what some people refer to as the M shape or the bunny ears. There is also a wide slurred S wave in the lateral leads. Let's now move on to talking about tachyarrhythmias. So again, the first thing we want to know is whether the complexes are broad or narrow, and whether the rhythm is regular or irregular. So we'll start talking about the narrow complex regular tachycardias. So these would be sinus tachycardia, atrial flutter, or AVNRT or AVRT. Let's start by looking at atrial flutter. In flutter, there is a regular reentrant circuit going around the right atrium, and this is usually running at around 300 beats per minute. It will then usually be only a number of those impulses, but at a regular interval that is passed through the AV node, and then ventricular conduction and depolarization is normal, giving the normal QRS width. This ECG is an example of atrial flutter with 2-to-1 block. You can see sawtooth flutter waves, particularly in the inferior leads, so 2, 3 and AVF. And as the flutter is running at 300 beats per minute, there is usually one of these flutter waves for each big box of the ECG. In this example, as there's a 2-to-1 block, that means every second wave is transmitted through the AV node. We therefore have a rate of 150 beats per minute. The next regular narrow complex tachycardia on our list is AV node reentrant tachycardia. In these individuals, there is an additional pathway within the AV node. Given the right circumstances, a repeating loop around the AV node re-exciting itself can occur, and this passes on a rapid rate to the ventricles. As excitation is coming from that rapid repeating loop going round and round the AV node, there are no P waves because it's not the sinus node that is activating. Once the impulse gets through to the ventricles, as long as there's no additional conduction block within the ventricles, that conduction through the ventricles will be normal and therefore it's narrow complex. The loop occurs at a regular pace and therefore this is a narrow complex regular rhythm with no visible P waves. AV reentrant tachycardia, as opposed to AV nodal reentrant tachycardia, is fairly similar, but here the additional conductive pathway occurs elsewhere between the atria and ventricle. The classical example of this is Wolff-Parkinson-White syndrome, but the consequence is fairly similar, that given the right circumstances, a electrical signal can pass down that additional pathway and end up in a recurring regular loop between that pathway and the normal conductive pathway of the AV node. All of these impulses being transmitted through to the ventricles at a fast rate. Your ECG usually ends up looking the same as a AVNRT, so a narrow, complex, regular tachycardia with no visible P waves. In some circumstances, if you've done some extra reading, you'll realise that with AVRT you sometimes get pre-excitation or delta waves, and this can make your QRS complex slightly more broad. But I don't really want to overcomplicate things here. I would simply recall a AVRT as a narrow complex regular tachycardia with no P waves. Let's move on to thinking about our narrow complex irregular tachycardias. And this is generally always atrial fibrillation. So here you have chaotic activity within the atria from multiple foci, and these electrical signals are passed intermittently through the AV node, but not at any regular interval. So this means you get a irregular ventricular rate. But as long as conduction within the ventricle doesn't have any further blocks, this should be normal through the ventricle, so it will be a narrow complex. In atrial fibrillation, as electrical signal is not coming from the SA node, but instead is from chaotic multiple foci within the atria, there is no clear P wave or flutter wave seen. But the transmission through the ventricles should be normal, so we've got a narrow complex. So this is a narrow complex irregular tachycardia with no P waves visible. Moving on to our broad complex rhythms and starting with the broad complex regular tachycardia, which until proved otherwise is ventricular tachycardia. Here, abnormal tissue within the ventricle, often related to, say, a scar after a heart attack, can form a reentrant loop that runs round and round the ventricle. As the conduction through the ventricle is abnormal and not through that specialist conductive pathway, the QRS is broad, and this reentrant loop is rapid, so you get a fast, broad, complex tachycardia. And this is what that reentrant loop within the ventricles translates to on an ECG. So you're not seeing any P waves, you've just got a broad complex of a single morphology which is occurring rapidly. So a broad complex tachycardia. With a broad, complex, irregular tachycardia, the thing that you really have to worry about is ventricular fibrillation. This looks like a child's scribble or my boss's handwriting often. This is basically just the ventricles spasming, and this really doesn't occur for long before the heart stops altogether. So actually it's very rare that you see a 12-lead ECG of ventricular fibrillation, because you really have a lot more to worry about than sticking 10 stickers on that patient's chest and calmly performing an ECG. Let's briefly talk about the initial assessment and management of arrhythmias, and you may well have already covered or will cover this in the acute care block. So the first thing you're going to do is assess the patient, and do this with an ABCDE approach, and do the basics like giving the patient oxygen if they're hypoxic, doing a 12-lead ECG, getting IV access, and if you can, identifying if there are any reversible causes of the arrhythmia, such as electrolyte imbalances, particularly potassium. And what we're really looking for here is any particularly adverse features, such as shock, low blood pressure, syncope. If the patient has a tachyarrhythmia and they are showing these adverse features of shock, syncope, low blood pressure, then there's really only one direction we're going in. We're gonna rock down to Electric Avenue, and then we'll take it higher. Oh, we're gonna rock down to Electric Avenue, and then we'll take it higher. Translated from Eddie Grant, what we're going to do is CardioMed-Ed the patient electronically. And we would start with 3 attempts of this. Hopefully this would restore sinus rhythm. If not, then we can try chemical cardioversion with amiodarone, followed by a repeat shock and further IV amiodarone over a 24-hour period. If the patient is stable, then the first thing we want to know is their QRS narrow, less than 120 milliseconds, or is it broad? If we've established that we have a narrow QRS complex, our next question is whether we have a regular or irregular ventricular rhythm. If we have a regular narrow complex tachycardia, the diagnosis is likely AVNRT, AVRT, or FLUTTER with 2-to-1 block. The treatment would therefore be first to attempt vagal manoeuvres. If not, we can give adenosine, which acts and blocks the AV node. This will either stop a AVNRT, or it will pause activity through the AV node and therefore allow flutter waves to be seen. We would do continuous ECG monitoring while we did this. If we have a narrow, complex, irregular tachycardia, the diagnosis is probably atrial fibrillation. If the patient is particularly unwell and we're not concerned about thromboembolic risk, we can consider cardioversion straight away. If not, we would give medication to aim to rate control the atrial fibrillation. If we have a broad QRS complex, again, we would next ask whether we have a regular or irregular rhythm. If it's an irregular broad complex tachycardia, you probably want to seek expert help straight away. To be honest, you probably want to seek expert help even if it's a broad complex regular tachycardia. The diagnosis to rule out with a broad complex irregular tachycardia is ventricular fibrillation, although these patients are all going to be unstable, so hopefully you would have stopped much earlier on this algorithm and put the pads onto the patient in order to shock them. If it's a broad complex regular rhythm, then the diagnosis to worry about excluding first is ventricular tachycardia, because this is a serious arrhythmia that the patient will not tolerate for long. Again, the patient is likely to be unstable and may need cardioverting straight away. And I will leave you with these words of wisdom from the IT crowd, simply because this explains what we're doing when we cardiovert a patient.
Hello, IT? Have you tried turning it off and on again?